Hello.
Hey,
How's it going?
I'm doing good. How are you?
I'm good. So what's going, was there new legislation with 708 or something? I know, I mean I don't know, maybe a month or two in Florida we banned it, but like that wouldn't cause the influx today.
No, I guess what happened was I just posted a video, and I woke up with like over 50 messages,
Wow.
talking about how people all over the across the United States are on it and want to know what to do to get off. They've just been silent this whole time, suffering.
I had seen like a smattering of I mean, people used to be saying, "Oh, it's great. It's how, it's like an alternative to buprenorphine," but I guess
Right.
well, Florida banning it, I guess is getting people scared that it'll be banned elsewhere, probably.
Probably. And then just the difference between, I've always heard kratom, and I even consider that myself as far as getting off of full binding opiates, or opioids, if you will. I considered kratom, but you just never know with the manufacturer, this, that, and the third. And I really can't help people with that as an alternative. So that's why I always push the Suboxone route,
Mhm.
even if it's just for a little bit.
That's, I mean, what I write about for my other clients. I've been doing a lot of manufacturers of all medications, just the difference between different manufacturers. I've got one on opioids coming out very soon, but yeah,
Good.
there's just, especially with supplements, because they're not really regulated like at all.
At all. There's no
No
overseer. It's
idea
kind of
what's in it.
like
Like,
what we say is what we say,
yeah.
you know?
But even drugs, like, our oversight has not been good for the past, I don't know, decade or two.
Yeah, I agree. I've seen, yeah, been in the medical field for 18 years and it's changed dramatically since I would say like 16, 17, 18. Yeah, I've been noticing a big difference.
It's crazy.
Yeah. Are we just waiting on Dr. Triggs? Is it Trigg or Triggs?
Trig,
Trigg. Okay.
singular.
Okay, got
It's
it.
Trig, yeah. He's just a heads up, he will ramble.
Okay.
When I did the interview with him before, it was like an hour and a half. I mean, it was fascinating. He has a lot of good stuff to say, but sometimes it
Yeah.
takes a second to like you got to direct him back to the point sometimes.
Okay,
He
got it.
will he'll ramble. But he's
Yeah.
very knowledgeable. He's a little bit older. He's been doing this for decades. He was, one of the original harm reductionists back in the day,
Wow.
several different states. So I figured he's still, a good source, even if we got to chat a little
100%.
bit. Yeah.
Yeah. So also real quick, I just went on live and was getting some questions from my people and just wanted to make it short and sweet because as we know, he may ramble. So
Yeah.
I wanted just to point on some really, really good topics. Is that okay that I do that? I
Oh
mean,
yeah, absolutely. I mean, so
because he,
the questions I sent were just sort of like set the stage, and then I figured the
sure.
things you're getting are probably much more specifics. But are there any that stand out to you, just so we could both be on the same page, and I can help direct him back if need be?
Yes, absolutely. So 7OH and kratom, obviously, because there's a big difference. And
Hmm.
then benzos while being on Suboxone and methadone.
So like, if you're misusing them, like, or can they make like, what is the interaction? Or
Yeah, basically just why I guess a lot of patients are saying that they're not getting treatment. Like if they're on Suboxone, they cannot have a benzo. And I know that there is a way to do it. You see an addiction specialist, they usually want you to see like a psychiatrist separately for that, and understandably. But a lot of people are hitting those roadblocks, so they're just continuing to relapse and relapse and relapse because doctors aren't comfortable. The same doctor's not comfortable prescribing both. I just wanted to know why that is, and I know that they do interact,
yeah.
but is it just because they're an addict? And then the tooth decay with Suboxone, I was, of course, that's just ongoing. I just didn't know if you had any insight on that. And
I had to
then,
block that. Do you get that woman? She's an older woman doctor that's like really against Suboxone and is always. I had to block her. I was just like,
well, I
people,
do
stop
too.
tagging this woman in my. Oh, Bruce is here. I'm gonna let him
Okay.
in.
Okay. Yeah, I had to block her too.
Hello, Dr. Trigg. Can you hear us?
Good evening. Yeah, I'll even go on video.
Perfect.
Okay.
It's good to
Mm.
see you.
Yeah, hi.
So,
Hey.
Jen, this is Dr. Trigg. I was telling you he's, one of the original harm reductionists in my mind, as far as I can tell. He's been practicing for a long time. Right now, he's in St. Anne's in New York, St. Anne's Harm Reduction in New York. Dr. Trigg, this is Jen. She is a content creator on TikTok. She takes buprenorphine herself, and she has helped direct, what, 70 people to help get medication-assisted treatment?
We're QuickMD notified me I've sent 400 people their way.
Wow.
Yeah.
Can you
So
can you say that a little again, a little slower?
Sure. So Quick MD, actually, I work closely with them. I sent over 400 people their way. They actually reached out to me via social media. And I connect people to several resources across the United States, depending on insurance and what state they're in due to regulations for telehealth Suboxone to get them off of the street stuff.
Awesome. Yes.
Yeah.
Yes. So I am unfortunately no longer at St. Anne's.
Oh no? Mhm.
They ran out of money to pay me.
Oh, well,
Um,
that's unfortunate.
so that is unfortunate. I was there one day a week. It's not like I lost a full-time job, but
Yeah.
I have huge respect. That is the oldest harm reduction um, syringe service program in New York City.
Yeah.
Their founder, Joyce Rivera, is truly one of the founders of harm reduction. I sort of came a few years later, but I have been a buprenorphine provider for 20 years.
Wow.
Um, and I am very much an advocate and a activist in expanding
Absolutely.
access. Where do you live, Jen?
So I'm in Dallas, Fort Worth, Texas. Again, I work with people all over the United States. I have connections with like Bicycle Health, Quick MD, Work at Health. I mean, that's just to name a couple. Ophelia Clinic with a K. I have probably 10 that I know a direct
You say
physician.
Ophelia, the online
Yes.
yeah, yeah,
Yeah.
yeah, yeah, yeah. I do know about them, of course.
Yes.
Yeah. So my specialty is medications for opioid use disorder, methadone and buprenorphine. I was director of methadone clinics at one time, helped start a methadone program at the large county jail in New Mexico, the largest jail in the state. And I've
Wow.
and I've been active in trying to get MOUD into jails and prisons,
Oh,
which has been an unbelievably difficult, challenging,
oh my
um,
God.
and now it looks like it's going to be going backwards
I know. Yes.
because of the idiots who've taken over the government. So we're in, I'm really concerned about that. A number of states, got these waivers that um, um, allowed Medicaid to pay for
You got it.
MOUD before release from prisons. And I always thought it was a ridiculous excuse that they didn't have the money. It's compared with the cost of incarceration, it's never been a significant factor. But having to say, and it won't even cost you anything,
You're right.
sort of helped.
Yeah.
But now I think it's going to be going backward.
Backwards.
Only two or three states really have systems of MOUD. New York, California, most prominent.
Yep.
Rhode Island was the first. So
I want
you
to
have,
just back up a little bit
yeah,
for, anyone who's not quite as immersed in this world as the three of us are. How do
of
most
course.
people currently pay? Whether they're in, coming out of jail or they're just, members of the community. How do they currently pay for MOUD?
Okay. The vast majority of people pay for it with public insurance, with Medicaid. All my patients in the Bronx had Medicaid. And in fact, some people with private insurance, the copays are so high that
Yeah.
there was another state program, fortunately in New York,
Mm.
that would pay for it, um, even though people had insurance because they couldn't afford the copays. But I think
Right.
very few states have that kind of generous program. Washington State ha has a similar program. So
Yes.
so basically, Emma,
Mhm.
it's unaffordable. I mean,
Yep.
um, at the best, with generic products and relatively low doses, it's maybe $300 a
Month.
month. Yeah.
He's right.
Um, but yeah, I mean, it's just and methadone is about $15 a day. Maybe it's up to 20 now.
Yeah.
Um, and it's just not affordable to people who haven't been employed and haven't been they are absolutely life-saving medicines.
Yeah.
Even if you
They're
are
life
employed, that's a
changing.
significant expense.
Yeah. So it's a significant and so I mean, we finally have gotten the overdose death rate
I know it.
down, even though it's still obscene and the highest in the world. but it has been going down. And I think the changes in insurance, the loss of Medicaid, and the other general worsening of people's social situation is going to lead to an increase in deaths. And
I agree.
you agree? Yeah.
Yeah, and also I'm a medical professional. I've been a nationally registered certified medical assistant since 2008. So
Oh,
I've
really? Uh-huh.
yeah, I run an internal medicine practice now. I've worked with doctors who prescribe Suboxone back when it was just only so many people could, or a psychiatrist could. But then now the laws got lessened, and and then now you take a class and it became readily available via as easy as telehealth, which was such a blessing for people like for a shame and guilt go. And then at one point, I'm on Marketplace. If you're familiar with, like a marketplace, it's kind of like the Obamacare that changed
Yeah,
into
yeah, the healthcare
federal,
exchange.
the healthcare exchange. So that's how I was obtaining and receiving my Suboxone.
I see. That helps people with the premiums for Obamacare. Yeah, yeah.
Yeah. Yeah, because I couldn't qualify. I don't have the option for like Blue Cross or Blue Shield with my employer, but I don't make enough to afford $400, $500 premium. So it was kind of an in between because I don't qualify for Medicaid.
So that's what the shutdown on the government's about, right? Is about
Correct. So now
that
I'm completely
marketplace
out of pocket.
is about that. Yeah, yeah. No, it's a disaster, and of course, since the disasters come every day, every time you open the news, the focus is not going to be on necessarily on people with drug use disorders.
For sure.
Do you have any point in history where this sort of thing happened before and we saw what happened that we can, reflect back on?
I'm sorry. Can you say that more slowly?
Has there been another time where, there were cuts to Medicaid or people lost their insurance to coverage specifically for medications for opioid use disorders, where we
Yes.
look back
Yeah.
and be like, okay, this ref looks a lot like that. We can kind of predict what this.
You're absolutely right. It has happened. It's been documented. I don't have it at the tip of my tongue, but there was a documentation of increased overdoses after some sort of cuts in Medicaid.
Mm.
That's been documented. I mean, um, to be a little cynical, actually, to be very cynical, I mean, all the studies, all this has been studied to death, and it's really a matter of political change.
Yep.
We know exactly what the story is. I mean, people in the academy, they have to do studies. That's what their careers are about. So they study all this, over and over and over again. But what can I tell you? You know,
Yeah.
poverty and mental health and lack of a healthcare system lead to people having problems in their lives, and the resources are unevenly distributed, and a for-profit healthcare system makes means that some people get good care and some people get minimal.
Is there anything that someone could do now, someone who's currently on Medicaid, they're worried about losing it? What could they do to try to prepare for that transition?
Yeah. That's really a key issue. And by the way, Medicaid, does pay for the meds, but
Right.
the most exciting new developments in medication for opioid use disorder has been use of injectables, long-acting injectables for
Right.
starting people on buprenorphine. Just in the last couple of weeks, I learned about, and I think I sent it to you, Emma, right? That
Mhm.
those studies that I don't know if you know about this, Jen, but the big challenge with buprenorphine has been that people have to be in withdrawal.
Correct.
Um, and as everyone knows, to a medical professional or to the lay public, oh, so you're sick a bit, what's the big deal?
Hmm.
But subjectively, to someone who uses drugs, it's just a devastating experience.
I
So
actually
it's
had
been
someone
thought.
message me on TikTok saying that he wanted to get treatment, but he was terrified. He was like, I can't do the 3 days in withdrawal. And I said,
Correct.
lucky for
Same.
you, that's starting to finally change. But
So people have developed one that I'm aware of in New York that they do at the On Point overdose prevention centers
Mhm.
and at Montefiore Hospital, where they start people with a weekly injection of a 1 week medication of buprenorphine called Brixadi.
Mhm.
Yes, I'm familiar.
And the advantage of this is people don't have to be in withdrawal. In fact, they could have just used an hour ago.
Even though it's buprenorphine?
Even though it's buprenorphine. It's such a, the way the onset is, it does not
Mm,
go into withdrawal. So you
wow.
start with an injection, that's a 1 week injection, and then a week later, you come back and you get a monthly injection. And they've been having success with people who were using an overdose prevention center, so clearly people with not a lot of means or resources. And then the study in Washington that was published that I sent Emma was a 3-day start, where on day one you get a 1 week Brixadi. On day two, you get another 1 week Brixadi, but double the dose. And on
Mm,
day three, you get a 1 month injection. And 2/3 of the people came back in a month for the second injection.
wow.
And if I had 2/3 of my patients coming back after starting them on buprenorphine, I would be extremely happy.
Yeah.
That's actually
So
something we had talked about last time we spoke, right? The about the higher doses that people are using of buprenorphine now and finding success, whereas for a long time we thought that 16 to 24 was it.
Yeah.
so my frustration is that we're on the verge of some really exciting new things
Hmm.
that are being, people are doing because they want to serve their patients, and this is going to be impossible. Those injections cost
Thousands.
thousands of dollars, thousands. So
Yeah.
talk about $300 a month. We're talking about $2,000 injections.
I can't do it.
Um,
Yeah.
and I'm not sure, it would be a struggle even with current Medicaid to get them, to cover it.
Sure, yeah.
Each state's gonna, because of our health system, each state has to work out its own
Right.
Medicaid and how it's going to be accessible. Most of the syringe service programs in New York City that are funded to do buprenorphine haven't even started doing the long-acting injections just because of all the com com basically bureaucratic hoops they have to jump through.
Right.
But this has been, but we've been pushing, trying to do that. But now, if people don't even have Medicaid, it's not going to be possible.
No, it's not.
Is that something that the overdose prevention centers or, even other clinics like, a methadone clinic or uh, addiction treatment center for buprenorphine, do they have people that can help you navigate insurance? Is that something they will help patients with?
Um, Good question. I think it varies. I
Okay.
think, I mean,
I'm trying to
uh,
think of any
it,
little
it,
thing tidbit I
yeah,
could
yeah,
give a patient
yeah.
of hope,
I,
something they
Yeah,
could do.
methadone clinics are both about half of them are run by private equity.
Right.
They're
That's a big trend.
corporations, and the others are nonprofit. But all of them depend on. I mean, they all need the fees, and so it's in their interest to help people get insured. Were you ever on methadone, Jen? Did you?
I have not been. No.
Yeah. Yeah. So I think they do try to get people, covered by Medicaid. But again, the future of Medicaid is completely up in the air. In the past, when I worked in New Mexico, I remember, well, virtually only pregnant women in those days. Oh,
Right.
Medicaid was only for pregnant women and
Right.
children. Single adults, and people with substance use disorders were absolutely not
No.
did not qualify. So it was only because of this expansion under Obamacare, right?
You're
The
right.
Affordable Care Act that drastically increased the number of people on Medicaid. But my point is the states did prioritize like pregnant women and children.
Yes.
The states could, if they wanted to save the lives of people,
Yes.
MOUD. I mean,
Right.
I don't think there's any other medicine that you could say without question that
No.
this will decrease the risk of death by 50%. Right.
No.
It's
I
Right.
huge.
agree.
Yeah.
You know what I mean? I mean, it would be, justified from a public health point of view to prioritize people who use drugs. But I'll let you all estimate the likelihood of
Yeah.
a state government going, we're going to give priority to people who use drugs.
Right. And what's really sad is I heard our top dog, say, why would we give money to people and help the addiction continue? Why would we continue to support the finances of helping addicts continue to be addicts? And that's the way that they look at it. And that's our government. And that is so.
Well, you know, yeah, you all know this well. So, by the way, are you both familiar with Drug Policy Alliance?
A
Yes.
little bit.
And you're coming to their meeting in Detroit in November?
I
No.
don't yet know if I'm going to be able to make it. I
Yeah.
want to for sure, but
Well, you need to go so you can meet me in person, and I'll introduce you to my daughter, who's a social worker and working in this field as well. Yeah, it's a very dangerous and time, and in,
Okay.
in in so many ways. So Emma, you do a blog, right? Or a
yeah, so I have the Substack. I'm actually also working on an op-ed right now for undark.org about increasing access to buprenorphine. Honestly, the premise of that is more about stigma. There was that recent study that came out that said, I think it was more than 30% of doctors said they would just rather not work with patients with addictions.
Yeah.
And there was one of the main questions that they asked them was why, and they said, "Oh, we don't think we can help them." But buprenorphine is a super easy drug to prescribe. It's not that dangerous or risky. So that's essentially what that op-ed will be about. So, we could get into that a little bit here too, but I want to make sure we get to Jen's question since I set this up
Yeah.
mainly for her because she's been getting so many questions on TikTok lately. Um,
Yeah,
all
Dr.
right.
Trigg,
So 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 you want to why don't you take the lead? I mean, I can go on and on, but
sure, Dr. Trigg, first of all, thank you so much for your time. This is going to help. I have close to 10,000 followers and they reach out. I mean, I have
you have
hundreds of
10,000 followers
almost.
on TikTok.
Yeah. I'm almost to 9,000. So I like to say 10,000, but yeah, they're
Well,
growing.
whatever you say about me, I'm never going to see because I don't have TikTok.
Well, they'll see this parts of it. So let me ask you,
Are
I
we
had like,
actually being taped or
yeah,
yeah, so this is being recorded, but if you're not comfortable with that, we could just use audio or write it down or,
right.
film our own things.
I have nothing to hide, and my political views aren't
We'll
going to
skip
change.
that. We can
Aren't going
skip
to
right
change.
over
All
that.
right. Well, yeah.
We don't want to alienate anybody. That's part of
No,
so I try to keep it not political, even though I feel very strongly about politics because I
right.
don't want people that disagree with me to not get care because of it.
Correct. Same way.
No, I do understand, and I mean, I don't, I have a professional relationship with my patients. I don't tell
Yeah.
them
Yes.
how to vote,
But I
but
mean, this one is inherently political because we are talking about,
Yep.
Medicaid. So we can't escape it entirely.
No, we can't. You're right. I
the
mean,
whole
it's
government
happening.
is shut down.
Yeah.
It's exactly over that.
I mean, we can avoid giving the middle finger to our commander in chief, but that's about it. Like,
Yeah.
Well, can we? No, I'm just kidding. Yeah, Dr. Trigg. So I just have like 6 questions here that this is like basically
Yeah.
what my followers really want to know. And I'll just start it off with just benzos and Suboxone and Methadone. Why do so many providers absolutely say no, no, no? Do you believe in the fact that this could be a safe plan of care? For example, I am on diazepam for debilitating social anxiety, isolation, panic disorder, and have been since before I had addiction, right? So, what's your thoughts on benzos with Suboxone and Methadone?
Okay, it's a complicated and a long story, and I've
Okay.
changed my views on it because
Okay.
at one time the Food and Drug Administration said that they do not mix, that they should
Right.
never be combined, and I was, I mean, like all you mentioned that doctors, they don't think they can help people. I learned nothing about addiction in medical school, and I
Right.
and I was a pediatrician and I never prescribed benzos. So this was, so I'm trying to help patients and it says it's dangerous.
Mm-hmm.
I would say no, in fact, we would test people and if benzos were in their urine, no matter how they looked, whether they looked great or they were, if and benzos can stay a couple of weeks in the urine.
Yeah.
And I would say to people, come back in 2 weeks when your urine would have cleared. And I feel guilty about that because I think
Yeah.
patients didn't come back and maybe they didn't survive.
Oh,
But a
yeah.
year later, the Food and Drug Administration, because of experience, I'm sure a lot of negative experience, said reversed it. And they said, no, it's still safer for people to be on buprenorphine. So that is currently the recommendation, because a risk of death from fentanyl is far greater than the risk of you have of not putting someone, not putting someone on it. Now, on the other hand, I do think that people should be on, well, it's the question is how much benzos?
Right.
Are
Or
they
what kind? Like
what
fast acting,
kind? Are
long
they
acting?
prescribed? Does the provider who prescribes them know that they're prescribing it for someone with an opioid use disorder?
Correct.
Now, I've called doctors and nurse practitioners and said, I'm the doctor of your patient, and in a methadone clinic, or I'm prescribing buprenorphine, and they would be like a silence on the phone
Right.
because the patient didn't tell them um,
Correct.
they had an opioid use disorder, and then they would say, "Oh." They'd be embarrassed. I'll stop it immediately. And then, of course, I'd have to say, no, don't stop it
No,
immediately.
don't.
That's very dangerous. And
Yes.
and actually, I've had psychiatrists ask me how to taper people off because so actually guidelines have just come out from the American Society of Addiction Medicine. Are you familiar with that? And
Yes, sir.
and another group just came up with guidelines for tapering people.
Yep.
So the answer is if someone is doing well and they're not over sedated and it's helping them, I think you should be patient-centered and explain to the patient the risks and the concerns
Okay.
and encourage people to taper down.
Yes.
Ideally, the same doctor who's treating the addiction is also treating the anxiety with the benzos.
Okay.
But I always say to patients that there are effective treatments for anxiety.
Uh-huh.
And as we're tapering you on the benzos, we could also start you on an SSRI.
Yeah.
We've actually had great success with some patients.
Yeah.
And when I say a taper, I mean one patient for 2 years we would
Yes,
taper.
that's what we look at, like a milligram a month with intermittent stabilization, 10%.
So this is called patient-centered care.
Mhm.
Hmm.
It's the way everybody should be treated for anything, right?
Right. You would
Right.
think.
You know,
Yeah.
talk to the patient. But it's true that original warning did scare me,
Mhm.
and again, I wasn't that experienced at the time. And,
Yeah.
it
How
scared.
long ago was that? Where you were saying no? And then what year do you think?
That was when I was probably 15 years. No,
Okay.
yeah, 15 years ago. Yeah. It
Okay.
was
Just
a long time.
I mean,
curious.
certainly though, for a lot of people, you still see headlines about the mixing of benzos and opioids, particularly, I mean, it's in the context of, using street drugs and things like that, but I could
Uh,
see how, somebody who's a little bit less experienced might immediately bristle at that combination because they've seen those headlines. They understand, as you said, that there is an inherent risk of mixing them and they're,
Respiratory distress. And
yeah.
then, so for example, my Suboxone doctor, she's a nurse practitioner. She will not treat me with the benzo. She's referred me to a psychiatrist, but the psychiatrist will treat me with the benzo, but not prescribe the Suboxone. So they won't. Do you see how they avoid that issue there? But
But they're at least they're both still willing to treat you, but that is still quite a hassle. I
And
can
do they
see.
actually speak to each other?
Yeah.
no,
No,
no.
no, no, no. I mean, so this is the story. I really think people, and this is the current, you know, advice, expert advice, is people should not be on chronic benzos,
Okay.
period. But that wasn't true 10 years ago.
Right.
I mean, that wasn't the standard of medical practice.
Right.
Most people were started by doctors on benzos. So
Yeah.
it's not like they did something wrong. You went to a
Right.
doctor, you were anxious, and benzos, of course, work. They work very quickly.
Yes.
SSRIs take weeks or months, right? And you have to play with the doses, and it's
Sometimes you have
so
to try three different ones to find the right
Yeah.
one for you.
Takes a while to kick in. That's the issue, is people need relief
that's
now.
absolutely, and sometimes it makes things worse before it makes things better.
Right.
So it's a complicated thing, but
Yes.
I have seen it work. I have seen this technique of it's keeping someone on buprenorphine, working with their other provider, or taking over their benzo,
Yes.
prescription and slowly tapering them and being very patient about it. And
Yes.
again, I mean, it's the way we all want to be treated, right? With like
Right.
human beings and
Yeah.
intelligent human beings. But so it's no longer forbidden,
Right. Thank you.
Where do
but
drugs like
but
clonidine come in here? Because I know sometimes those are used for withdrawal, particularly those kinds of agitation type symptoms. Do they play a role in any sort of long-term maintenance?
well, that's interesting. Clonidine has been used for a very long time for
Yep.
withdrawal symptoms, and often it was used instead of giving people methadone or buprenorphine. They would just, or you're withdrawing. They used to call it kick kits,
Yep.
right? But it actually works. It's not as good as, for withdrawal, right, as buprenorphine or methadone, but it
A lot of
does.
people do both now, right? They
Yes.
I prescribe it for every patient I start on buprenorphine,
Mhm.
and I prescribe it for every patient on buprenorphine who's still having cravings.
Mm.
And
Oh, interesting. Okay.
yes, and nowadays the recommendations for starting people on buprenorphine, whether you're doing it microdosing,
Yeah.
or macrodosing, is to give people what they call, comfort meds or
Yes. That's
right.
how I know it.
And clonidine is at the top of
Yep.
every list. And in
Yep.
my experience, it's the most effective. It's
My loved one says it works. He
okay.
was asking for it.
It's a blood pressure pill, Emma, and it's by the way, it's off label in the
Yep.
use for withdrawal. There's a much more expensive one that's on label,
Yes.
but I don't, I don't think there's any demonstrated superiority to the other medication. I don't even know the name. I can't. It's not on the tip of my
I
tongue.
can't think of it either, but I
Yeah,
know
but
exactly what
I've
you're talking
always
about.
used clonidine. And by the way, some of my patients, months later, years later, they still say, "Oh yeah, I see them." And don't remember, doc, give me some clonidine.
How
So,
does that help cravings though? Or what are
well, it's very hard to say. It's an alpha 2 agonist. It's really relieves anxiety for some,
okay, that's
but
what I
it's
was thinking.
specifically been shown to help with cravings,
Okay.
I
right?
mean, a part of that, at least currently, is related to the xylazine and medetomidine in the supply, right? Because they're also alpha 2.
Can you say that again, slower?
I think part of the reason they're helpful right now, I mean, historically, I'm not sure, but right now, because the illicit supply is tainted with xylazine
You're
or
right.
medetomidine, those are both
Oh, yeah.
alpha 2 agonists, right? So clonidine
Yeah.
really helps specifically with the withdrawal from those adulterants when you're.
That's interesting. Yeah, you're right. You're absolutely right.
Yeah.
And I think that it's used to treat like withdrawal from
Because there's really nothing, yeah, for this.
medicine. Yeah, yeah, but
Good point.
yeah, that is a good point. But it's a safe medicine. I think
Yes.
it can be overused and
Yeah.
probably misused. I usually just prescribe like point 0.1 twice a day. And
Yeah.
then, if someone's in a situation that they have a triggering situation, I say just pop one. I mean,
Yeah.
um, it gives people, control, and it's safe.
Yes.
And so I am very generous, and the current guidelines are to be generous with these ancillary medications
Okay.
for treating headaches and stomach cramps and diarrhea,
Yeah.
and sometimes giving, gabapentin,
Mhm.
um, and also, by the way, benzos.
Hmm.
A few days of benzos aren't going to kill somebody, and
No.
especially if someone's super anxious about starting buprenorphine,
Yeah.
it's perfectly reasonable to give them, right?
A
Um,
small dose benzo. Yeah,
yeah, a few
absolutely.
days. Yeah, I mean, there's a tendency, among doctors. I mean, just to be
Yeah.
sort of overly, you know,
Okay.
to be overly cautious. I mean, it's probably better to be overly cautious than under cautious.
Right.
But
I know.
the thing is, you want to find a reasonable balance. But if someone tells me, they take benzos for anxiety and they're super nervous about starting, it's going to save their life to start buprenorphine. So
That's something that's come up in a couple
why
conversations.
don't we give them 3 days of,
Yeah.
the Razepam, right?
I've been hearing some doctors say, we're so worried, particularly with methadone, about the risks of overtreatment that we forget about the risks of undertreatment completely.
Wow.
Underdose people, things like that.
Yes.
Because the clinic is liable if you have a problem with the methadone. They're not liable if you have a problem with if you crave, relapse, and have a problem on the street.
Or fall off, yeah.
No, there are big flaws in the system. The best news I have for both of you is that the young, best and brightest people that I know, doctors and nurse practitioners, are really embracing harm reduction and addiction medicine. Addiction fellowships are, at
Yeah.
least the ones I know about are attracting really good people to this field. And that's, American Society of Addiction Medicine has progressed tremendously.
Oh, yeah.
They're in line with harm reduction. They're for overdose prevention centers.
Yeah.
But is the change fast enough? Of course not.
So, yeah. But it's in motion, hopefully, for right now. My next question was I'm hearing so many people not get on Suboxone at all or methadone because they know their teeth are gonna rot out. How do we, I know that it can, cause and lead to the acidity from the medication can break down the enamel. Yes, but being proactive, is that not enough? Going to the dentist, it can't just make your teeth fall out. I mean, can you give me some insight, please, to tell
Yeah, yeah,
people?
yeah. This is it actually we've just been discussing this in New York, how that warning about buprenorphine. Um, op all opioids decrease salivation. So
All
it
opioids.
makes
Okay.
you more susceptible to tooth decay,
Mm-hmm.
especially if you're not taking care of your teeth. And,
Yeah.
I don't want to, like stereotype people with opioid use disorder, but when you're chasing a drug many times a day, I just doubt that people are brushing their teeth and flossing and
Right.
getting preventive dental care. So the only recommendation really is to rinse your mouth with water a certain amount of time afterwards, you know, and to pay attention to your dental hygiene and
Right.
and to get regular dental care.
Yeah.
Yeah,
Being
and
proactive, being mindful and being proactive. It's not going to cause, you're a doctor, can you say that it will not cause your teeth alone to fall out? I feel like I can.
no, that's just, this is, when I worked in methadone clinics, people they say it gets in your bones and it rots
Yes.
rots
Yes.
your teeth, and it was like, well, you weren't really taking care of your teeth before you came to the methadone clinic.
Yes.
By the
Thank
time
you.
by the time people started, their teeth were in horrible condition.
Right.
And of course, teeth status, care of teeth is really almost a measure of social class in the United States,
That's true.
you know.
Well said. That's
So
true.
so it's just playing on those, inequities,
Thank
right?
you.
Yeah. So I would tell people without question, you need to get on buprenorphine, and then yeah, tell your
Yeah.
dentist if you have, and get it. Even more important, get a dentist.
Yeah.
Again,
Get one.
Be
Right.
proactive for sure.
until you're on buprenorphine or methadone, you're not going to have a dentist. You're never
Right.
going to
Don't
see a
worry about
dentist.
it. Yeah.
Yeah. It's a side issue, and
And
yeah.
my dentist, I've talked to two of them in the same dental clinic, an associate and my regular dentist. He's great in Dallas, Texas. And he says it doesn't, the medication isn't going to cause tooth decay. It doesn't, poor dental hygiene and not going is going to cause the tooth decay. But people don't realize till 10 years after addiction, then now they're taking a medicine. It's easy to point the finger because they have a pending lawsuit. But so does Zofran. Zofran dissolves under the tongue and it has a pending lawsuit and can lead to dental decay because it imbalances the acidity of the mouth, just like you mentioned. But they don't talk about that.
No, everything around addiction is about stigma. It's all about,
Yeah.
I mean, yeah. I've never spoken to a dentist about it actually, but yeah,
Yeah.
but we have been talking in New York about putting out like an information sheet
Okay.
and if you come across a good one, a good information sheet of discussing the dental issue.
Great. And then also for Brixadi and Sublocade, how do you feel about those? For me, I've been running into a lot of people are jumping. They're on Suboxone. They're not on a stable dose for a stable amount of time. I believe in, depending on the severity of addiction, but you've got to be stable on a dose of Suboxone or Zubsolv or whatever, buprenorphine before you get onto the shot. Because if you're not, what I'm seeing happen is these patients are getting on Suboxone, Sublocade, and they are immediately needing to dose as well while they're on it. They're not feeling good, and then they don't go back for their second and third shot. Why is that?
Okay. I have very limited experience with the long actings, but I've been to a million workshops and I'm super excited now about these two new techniques because of starting people. So it used to be that you had to, for Sublocade, you had to be on what I think was a week of sublingual.
Yes.
And then and then they found that studies showed that all you needed was one dose of sublingual. Just give
Yeah.
someone one dose and make sure they don't have an anaphylactic reaction to it,
Right.
right? And then they gave them the shot. But the problem is it puts everyone into withdrawal unless you've abstained for enough days.
Oh,
And abstaining is difficult because if you're addicted, you can't abstain, right? I mean, you
right.
know, so the amazing thing is these two programs now, one with a study. Did I send it to you, Jen? This study I sent Emma?
No, I think you only sent it to me, so I don't think she's
Yeah.
seen this.
Okay. So if
Yeah.
you send me your email,
Sure.
it's a study out of Washington State where my daughter-in-law actually works with this program, and that's where they have this new recovery center. But that's where the doctors came up with this 3-day induction of
Hmm.
three long-acting shots in a row.
Yeah.
But even with the three long-acting shots in a row, many people need to be taking sublingual for a period
Mm.
of time past that. So
Okay.
experience, my understanding is that for Sublocade and Brixadi, people still need sublingual for some period of time. So
Yeah,
you
that's
need,
great.
so, like I said, I haven't been doing it, so but my colleagues who do this say they always give people enough sublingual as back.
Okay.
And then
Thank you.
usually once people are on a high monthly dose for a while, they say, we're only going to do this for a month or two.
Right. Well, that makes
Because,
sense.
because I have to say, it's hard to convince people that they don't need constant opioids because their whole
Yeah.
experience is that you need constant opioid. You know what I mean? It's
Right.
to get people to trust, right?
Right.
Psychologically.
And the oral fixation,
Yeah,
the
yeah, whatever.
control.
Yeah, yeah. You know what I mean? And people, the whole experience is with short-acting opioids. So
Hmm.
the so for me to tell you I'm going to give you a shot and it's going to last a month, it just
Right.
flips people out, right? And
Right.
and that's even true with Suboxone, with the standard product. It's a once a day medicine.
Hmm.
I'd say less than half of my patients take it once a day. People think they need to keep.
Yes, I'm big on that. It needs to be as a single dose to be the best effectiveness. But I'm not a doctor, but I swear to my research proves and shows over 15 years in the field, 16 milligrams is a single dose daily to bind to the receptors and to leave it alone after that. But it's just more effective dose as a single dose. Do you agree with that?
You're saying it's a single dose medicine. Absolutely.
Yeah.
In fact, I know of a program that I had checked out in Vietnam where they gave it every other day.
Wow.
In fact, I think it's approved by the Food and Drug Administration for every other day
I
administration.
think you're right.
It's very long acting, but
Yeah, 38 hours half-life.
yeah, but you have to explain this to patients.
Yeah.
I had frequently a patient, they call late Friday afternoon and they can't get their buprenorphine and, it's, oh, I'm going to have to get some methadone on this tray. I said, no, no, you'll be fine on Monday. You'll be fine
Wow.
until Monday. But unless support patients and explain it to them, they
That's
think you're
true.
leaving them
High
hanging.
and dry. Yeah.
Are there patients for whom a split dose would be better? I know, for example, like pregnant women for methadone, they say split dose
Right.
seems to be better. Or if there's, chronic pain involved with the treatment, sometimes they say split dosing is better. Is that also the case for buprenorphine, or is that really just a methadone situation?
No, I think in both those cases, certainly for pain, pain is the same as methadone.
Hmm.
Um, Buprenorphine does not last 24 hours for pain. It's an every 8 hour, 6 to 8.
Wow. Oh, I didn't know
That's
that.
super, yeah,
Okay.
because there's definitely some populations that benefit, I think. Yeah.
Yeah, yeah,
Yeah,
yeah. And for pregnancy, it's beyond my expertise, but I have to say
got it.
it makes sense. It's a long-acting medicine like methadone, and metabolism changes with pregnancy. And if people are feeling withdrawal,
Yeah.
divide the dose. Yeah, and
Right.
of course the good news is that now that's possible with methadone, right? And
Yeah.
that never
Yes.
was that was never an option.
Can I ask you, when somebody's ready, like myself, I've been on Suboxone over a year. I'm taking 16 milligrams as a single dose daily.
Okay.
What would it look like for me to come down, come off? What would be, if we were to have this conversation, you are my doctor, and I know that you're not, but just say, what would that look like for a patient? How would you go about that?
Okay. So here's what I say to my patients. Okay. I say, by the time people in my age, everyone has one, two, or three chronic diseases, and we take a pile of pills every morning, and that's just part of life. And there's no stigma attached, right? Because the stigma is with opioids. Right.
Yeah.
So, so the problem is you have a chronic disease and you're not my age. You're a young person. Well, some young people get chronic diseases too. They have diabetes, right? And they take medicine the rest of their life. I never say the rest of their life, right? And I mean, I'm not Nostradamus, right? I can't
Right.
predict the future. But is the standard for any medicine, as long as you are benefiting,
Yeah,
you continue it.
I like that.
Um,
I've never been this productive. I've never had a stable job or relationship. I've got my first home, all of this while being on
So
Suboxone.
you're showing every success from Suboxone, right?
Yes,
And
sir.
and you're helping countless. How many followers do you have?
9,000.
Oh my God! So you're affecting other people's lives. But the point is, it looks like addiction is a chronic condition
Reoccurring, yes.
because the risk of overlap of relapse within 12 months of discontinuing is 80%, 80
Is
to
it really?
80 to 90%. And that's, it's not fun to have to tell people that statistic, but that is the reality. And it would be nice for me to think, oh, and if someone is doing as well as someone like Jen, then their risk is much less than someone who is sleeping in the subway outside, my house in
Right.
Manhattan. But the reality is that my favorite actor in the world died of an overdose. He was a
Amen. Yeah.
multi-millionaire and he had everything to live for,
Right.
and he died. He relapsed once and he died.
Yeah.
And supposedly he had been, I forget the number of years now, but he had been abstinent for many years, right?
Yep. Yes, sir.
So this is the thing. Would it have been better for him so only in retrospect do we know that for, 10 or 20 years he didn't use drugs, right?
Right.
But in retrospect, would it have been better for him to stay on buprenorphine or methadone for those 10 years, even though he didn't need it for those 10 years, but still be
Right.
alive today,
Huh?
right? As to stop the medicine, right? So here's the story. I take statins for cholesterol. And,
Mm-hmm.
and I'm not, an expert on this, but I think it's if your lifetime risk of heart attack is more than like 5%,
Mm-hmm.
you should be on statins. Well,
Mm-hmm.
I hate to say it, the lifetime risk of relapse is much higher than 5%.
Way higher.
It's
Yeah.
way higher. It's way higher. So if it makes sense for me to be on statins, even though thank God I'm healthy, it
Right.
makes even more sense for someone with a history of opioid use disorder to stay on it as long as they're benefiting from it.
Yeah.
You see what I'm saying? But on
Yeah. That
but
makes
on
so
the other
so
hand,
so
but
much
on the other
sense.
hand, the system should make it non-stigmatizing.
Right. I
Right.
mean, most
Shouldn't
people
be
don't
they
want to
have
get
to go
off
to a
because of the
methadone
drugs. They want to get
clinic
off because of the stigma.
5 days a week
Yes.
for the rest of your goddamn life, right? That doesn't make, so it's sort of so yes, you should stay on it.
Yeah.
People should stay on the medicine. But on the other hand, it should be non-stigmatizing and as convenient as possible. So you can have a
Yeah.
normal, I mean, no one gives me a hassle about being on statins. Oh,
No.
you're on a statin?
Yeah.
When are you getting off that stuff? And
Yeah.
right? You,
Yep.
you know what I'm saying?
Yeah, 100%. I wish people wouldn't, they rush to get off their drugs of choice, rush to get on Suboxone to go, how long will I have to be on this? And I go, I don't talk about the two D words, dose or duration. I don't talk about dose because you can't talk about that's not important. Stabilization is important. Stabilization.
Well, I think providers should tell people that make sure they understand. Because I have had patients come to see me and they think they're going to be on a 3 months, you
Mhm.
know. And so I mean, I'll give it to them 3 months. I'll give it to them for 3 days if they want. But I say I recommend, you need to know that this is really a long-term treatment, and,
Yep.
and I recommend a minimum of a year.
1 year. I knew you were going to say it. Oh, good.
You,
I'm glad we're on the same page. I love this.
you've been around enough doctors to know
I have.
how
I
doctors talk. So
thank you so
you've
much.
been on buprenorphine for
May of 2024. So about almost, about a year and a half. But I was sober. I've been sober 7 years. However, I was incarcerated and got out, and life got out in 2020. But by 2024, I realized I can't do life without some type of help. And I didn't even know really where to turn. But luckily, my medical expertise kind of steered me toward the Suboxone route. And I just said, hey, like I'm white knuckling life. If this is what it's like to be sober, the way I feel everything, I can't, I'm doing it, but I can't keep a relationship, a job. I'm just white knuckling, getting another day clean, getting another day clean. I'm clean, but I'm miserable. Dr. Trigg, I'm miserable. I wasn't happy. I wasn't thriving. There was no fun, no fire. My doctor said, you're such a candidate for Suboxone long term. Why not? I'm having cravings that are turning, triggers turning into cravings, relapse, sweating. I can't drive by certain places. I'm waking up, panicking in the middle of the night. I'm having relapse dreams over and over. It's taking me a whole day to get over these dreams. Ever since I've been on Suboxone, I've been stable. I won't say it's been great, but I've been stable.
What do you mean it hasn't been great? I mean, what does that mean?
I still feel, and people think it's numbing, people think that Suboxone numbs you, or that you're swapping.
Do you think Suboxone numbs you?
No, that's why I said it's not been great. It's
Yeah.
been good, but it hasn't been great. My life, we of course I go through the ups and downs and emotions, but um, I've tried to come off
That's life.
Yeah.
That is life.
without being on drugs. That's
Ups and
life,
yeah,
right? Yeah.
ups and downs. Yeah, a part of. But you're incorrect. I mean, you're the model. You're the model patient. You're the patient that
Thank you.
that keep people wanting to do this. It's an amazing medicine.
Yeah.
But
Thank you.
so Emma and I've spoken about. So
Mhm.
for most of my career in doing this, 16 was considered the maximum dose. I'd say to people, don't even ask me for more than 16. I won't give you more than 16. Insurance won't pay for more than 16. Everything I read says 16 is the maximum dose. Guess what? They didn't tell me the truth. It turns
Yeah.
out from the very beginning, they knew some people needed, you
It
know,
was I was talking to a doctor in Canada, and he said, "Oh, I saw one of your videos where I had mentioned, I think it was probably after our conversation, that the FDA had, the guidelines of 16 to 24 milligrams, and
Mm.
they recently got rid of that. And they got rid of the limit." And he said, in Canada, we never had that. It was always 32. We never had a limit in Canada. Like they never told
Really?
us that low.
so I've spent my entire medical career fighting for a single payer Canadian style national health system. So
Yeah.
So of course, and Canada's not perfect, by the way,
No.
anyway, but on addiction stuff, but they are so much superior. You know,
Yes.
I always say, people talk about the problems in Canada, and I always say
Yeah.
we should only have their problems. Yeah. So yeah, of course, Canada is they're very smart there. They do not have a corporate healthcare system like.
Right. They don't have that that box. I feel like we are in.
So
Yeah.
I know it is embarrassing sometimes to
Yeah.
be, to be an American. In New York State, Medicaid doesn't even require prior authorization for 32 milligrams. I think in some states, I think even going over 16 may still be a problem for
Uh,
Medicaid. The
Yeah,
problem
Texas.
state by state, and but so my point is, the right dose. the other thing, by the way, for a long time, I mean, for at least a few years, people are going, well, fentanyl is 50 times stronger than heroin. So obviously people need higher doses of methadone. But somehow it took a while for people to realize people also may need higher doses of buprenorphine, right?
Yeah, that makes sense. Yeah.
Yes. So I hope you'll, let your people know that if 16 or 24 isn't holding them, it's appropriate to go up to the right dose. I mean,
When is it appropriate? When do you, how do you dose? In my history, it's if you're watching the clock to dose, if you're thinking about it all day, if those are peak candidates to go up. I mean, obviously, because I can truly say I forget to dose sometimes because I'm stable, and that's
right,
what you
right.
want, right? Isn't that what the goal is?
Yeah, that's exactly right. No,
Okay.
yeah, you're absolutely right. Now, at the beginning, immediately buprenorphine takes away the withdrawals, and it takes
Uh-huh.
away um, it blocks the ability to get high. But the third advantage of methadone and buprenorphine is it takes away cravings, but
Yeah.
that takes a while.
How long?
Sometimes it takes weeks or months.
Okay.
So that's why I give people Clonidine.
Makes sense. Comfort
But if
meds in
it
between.
continues, but if it continues to be an issue, then it means you need a higher dose.
Thank you so
Now,
much.
now, often, unfortunately, doing this for a long time, there are people who still underdose dramatically. I mean, I see a patient, see someone in the street, why aren't you on bupe? It didn't work for me. Well, how long were you on it? Oh, for a while. What was your dose? 8 milligrams.
Yeah, or
Yeah.
four. Yeah.
Yeah, they were being underdosed. I mean, it's a medicine. It below a certain threshold, it doesn't work. So I always consider 12 the absolute minimum dose.
I love that. Okay, I'm on the
Absolutely.
same page. Yeah,
Uh,
that's
and
great.
that, yeah, but and also the other so I mentioned, in New Mexico where I worked for 35 years, but not all with buprenorphine, but patients would 16, was the maximum dose then, and most of my patients did great, like you, on
Yeah,
16. Their lives completely changed, but some people didn't come back, right?
yeah,
And
yeah.
those are the people that's my guilt now. What if I'd given them 24 or but I didn't think that was an option then.
Right. Well,
But
we know
now,
now.
so now
We
we do.
know.
Anyway, yeah. Anyway,
Yeah.
yeah.
Well, that's all I have, Emma. I don't know if you had anything, but
I
I
Did
answered
you
all
want
your
to touch on
questions.
the
Awesome.
70H?
oh yes, the most important thing. So yeah, I made a video yesterday and it did really well. I got tons of shares and I got 43 messages from people that are taking gas station 70H, as you know, is an alkaloid found in kratom, that they've compounded dangerously to mimic these 30 milligram roxycodones or whatever. So these people are on 70H, these stay at home moms, these children, these people. I'm working with a police officer and I'm working with a school teacher. And my recommendation is Suboxone, to get off of the 70H and waiting for going by the CAL scale, of course, and following the provider's recommendations, of course. But they don't know where to go or how to turn, and there's so much shame because it's this gas station that ruined them or that got them here, and they've been in silence for. I'm talking to people that have been doing this for over 2 years. They've been taking 70H.
I didn't realize it's been available that long.
I didn't either.
Um,
I know Kratom has, but I had
oh
no
yeah.
idea.
No, no, yeah, Kratom has, yeah. Have
Have
you
you
been
had
hearing
people in your
about
clinic?
70H, Emma, in your
I've touched on it a little bit, but I haven't really covered it a lot. But it seems like I'm gonna have to do more of it. Florida got
yeah.
rid of it recently, and I'm in Florida, so
Yeah,
we banned
yeah,
it. So
yeah.
yeah,
I've been hearing about it just in the last couple of weeks, and then before the call, I knew you were interested, and I just looked up the MMWR and that they did on it a couple of years ago, and then there was a report from the Los Angeles Department of Health, three deaths, three relatively young, healthy people,
yes,
and they also involved alcohol in all three.
yes, yes.
So this is, like any drugs, mixing them is an issue, but it's, completely unregulated product, and you never know what you're getting. And you're right, the treatment for addiction to kratom and 7-OH is buprenorphine.
Okay.
And the other thing is to make sure people are using it with all the appropriate precautions of opioids. Never use alone, always have naloxone, and always have a plan, right?
Thank you.
Always have someone who will
That is really key. I
be
don't
able to
think people
reverse
talk
an
enough
overdose.
about
No,
naloxone when it comes to 7-OH. They talk about they think it's safer. They use it as a way
they
to get off
do.
of opioids. And I hadn't actually thought of that honestly until you said it. Like that is really a
Neither.
message that is not, it's lost in translation. Nobody's talking about naloxone and 7-OH.
They're not.
I think that's really important that the word needs to get out about that. Yeah, it is. It occupies opiate receptors, and it needs to be. Yeah, we need to keep people safe. I think the FDA, they were blocked when they tried to schedule all of kratom.
Yeah.
Uh, but I think for 7-OH they're going to have a stronger case um and make it illegal.
Yeah.
Which is, of course, always a mixed bag
Yep.
because if you make
Mhm.
something illegal, it'll come back to us 100 times stronger, right?
Yep.
That's the miracle of the market.
Yeah.
They're not going to stop trying to make money. So,
And then just in general, yeah, kratom, you're obviously a medical doctor, so I'm sure you're kind of, about kratom as you'd never know where it comes from. It's not regulated. I really don't support it. I don't know where it comes from. I don't know who manufactures it. There's studies about kratom, but what kratom from where? It's Southeast Asian plant. I'm just pushing these people to go the Suboxone route. Do you recommend I continue to push them to do that as well?
rather than to try to self-treat their opiate addiction with kratom,
Yes.
absolutely.
Okay.
Yeah.
Thank you.
Yeah.
Okay.
And I do know people who after that route were then addicted to kratom and still needed to get on Suboxone. They got on
Right. Me
Suboxone
too.
to treat their kratom. Yeah.
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 All right.
Wow. Well, if you would send me your link, I would be I'll share it with my daughter-in-law and my daughter who do this
Yes.
work and are on social media, I suppose.
Great,
Okay.
yeah.
I'll be
Yeah.
happy.
Yeah. And Emma, and I'd be delighted to get on your Substack. Am
Yeah,
I on?
absolutely. So you have the link to I think I'd forwarded one of the emails, but if you just go, I can send you the link, dailymat.substack.com. It'll ask you to put in your email and then you'll get all the post via email. But you can
Yep.
also just look at it. I mean, it's basically like a news site if you go to that website. So you'll actually see I do have an interview with Jen. We talked a little bit more in depth about her story. Um, so we've got several posts there, but I can give you better access to that for sure.
That's awesome.
Excellent. Well, again, what you all are doing is, again, it's beyond my expertise, but I know this is the way to reach people today.
Yeah.
Very fond of a certain mayoral candidate in New York who's become quite expert
Oh
at
yeah.
social media, and it's gives me hope for the future. So,
Yeah.
as the two of you do. So anyway, so good luck. Anything I can do to help. I'm
Yeah.
sorry I'll miss you at DPA, but
Yeah,
they
I'm
all
gonna try to see if I can get there for a day or two.
okay. They alternate every year with the National Harm Reduction Conference.
Oh,
Oh,
okay,
okay.
yeah.
So
Good
Because
to
so
I mean,
know.
years ago I made it to the Liberate Meth, not years ago, 2 years ago, in 2023 I made it to Liberate Methadone in New York.
yes, I was at that. I
Okay, yeah.
just
My
had a
family's
couple.
in New Jersey, so that one was an easier one for me. But when
Oh,
I have Thanksgiving and I go back to New Jersey for that, and then I have actually
oh.
my dad lives in Portugal, so next week that's where I'm going to be next week. I said I'm out of town. I'm leaving Wednesday for Portugal, so I'm like Portugal in October, New Jersey in November. Can I fit Detroit in the middle? Like,
No.
so
Well, that's very interesting. I have good friends who live in Portugal,
yeah.
and
Whoa.
and
Small
they
world.
and they first moved there because one of them had a Fulbright to study
Oh wow.
drug, drug policy in Portugal.
I mean,
So
they have been the model for a while, but I feel like
they
there's been a little bit of a
it's very interesting.
downturn lately.
Yeah, well, it's still the best drug policy,
Yeah.
I think, of any country.
Wow.
You know about it,
Wow.
Jane? They've decriminalized all drugs.
I did hear that. I did my research. This was years ago, right? I mean,
Yeah.
long time ago. Yeah.
On the other hand, it's not exactly harm reduction. It's
No.
there
Yeah.
there are pressures put on people to
Right.
but again, with their despite their faults, it is
Yeah.
they're
Still a hell of a lot better than what we're doing.
not locking
Hell
people up.
yes.
What's that? It's
a heck of a lot better than what we're doing.
It's a heck of, and their overdose death rate is just a fraction. Yes. So I hope you get to talk to people there. We're in Portugal.
He's in Lisbon. He lives downtown. I mean, he just moved there
Wow.
semi-retired. It's a little bit cheaper than living in Massachusetts. So he was like, we're having fun. He's been there 3 or 4 years now.
Good for
Cool.
him. Portugal comes up a lot, and I was just visiting those friends in April, and
Okay.
Wow.
in Cascais. Have you been
That's
there?
I'm actually going there this time because not to get too far off track, but I like to do triathlons and there's a triathlon there on Saturday.
Oh,
So I'm going to Lisbon and then my dad and I will go to Cascais for the triathlon and then we'll come
oh
back
That's
my
so cool.
to it.
goodness.
Yeah.
Wonderful. Have a wonderful, safe trip, and
Thank you.
yeah. All right. Well,
Yeah. We'll keep in touch. I mean, this has been great.
anytime I'd be,
Yeah.
anything I can be a resource for.
And a really quick, you said how much, we were helping, but we couldn't do it without doctors like you. So again, thank you, Dr. Trigg.
You're very kind, but I learned everything I know from the harm reductionists who came to New Mexico when we tried to set up a harm reduction program. We didn't know what to do, and the
Wow.
people were unbelievably generous with their time, and they were some of the greats some of whom have sadly passed away. You know about Dan Big, who started Chicago
Yes.
I didn't
Recovery
see Dan Big.
Alliance.
I saw Louise though.
Hmm?
I saw Louise passed away recently, which was
Ah,
devastating.
what?
Yeah. Oh, you didn't know that, Louise?
No.
Yeah, she just died.
Oh,
Yeah,
wow. Okay.
yeah, yeah. And Alice Springer, um,
Yeah.
they came to New Mexico and they said, "This is what you have to do." And I still remember the first time that they said, "Don't call people junkies," and you know.
Wow.
And these, it completely changed, and New Mexico
Perspective.
still has one of the best harm reduction programs in the country, and it's all the influence of those people that came from Chicago and New York and said, "This is how you treat people."
And what was the name again?
Hmm?
What's the best harm reduction you said
In New
team?
Mexico, the name of the
Oh,
facility?
oh, the state harm reduction program. It's funded by the state. It's the New
Oh,
Mexico Department of Health.
okay.
Oh, okay. Hmm.
The
Got
last
it.
time I checked, they were exchanging in the state of New Mexico as many syringes, close to the number of New York City.
Wow.
New York City has 8 million people. New Mexico has 2 million people.
Two. Yeah. Oh my gosh.
Yeah, so
Thank you so much for your time tonight. I hope you both have a great night.
you
I'll
too.
talk soon.
Yeah,
Thank you.
take
Bye,
care.
Emma.
Good night.